Hello friends, I am Shobha from CNS and I welcome you to this very exciting new episode of NTB Dialogues, a special CNS series presenting insightful and thought-provoking interviews with those who have been at the forefront in fighting the world's top infectious killer disease, TB, to accelerate progress towards ending it by 2030 as promised by our governments. Today, we will be in conversation with four eminent scientists, Dr. Nerges Mistry, Dr. Kalpana Sriraman, Dr. Ambreen Shaikh, and Dr. Renu Verma. Dr. Mistry is Director and Trustee of the Foundation for Medical Research, or FMR as we call it, in Mumbai, and the Foundation for Research in Community Health, Pune. A microbiologist and immunologist by training, Dr. Mistry's work encompasses infectious diseases with a recent focus on antimicrobial resistance stewardship, TB transmission, infection control, and nutritional approaches for better outcomes for patients. Amongst her numerous scientific contributions is a mask-based aerosol capture method for COVID-19 to understand viral transmission, which she and her team had developed. And we'll be hearing more about her latest trophy which she has got, and rather put it for us for use. Dr. Sriraman is Assistant Director of Research and Administration at the Foundation for Medical Research. In tuberculosis, her main research area is the molecular biology of TB disease, with a specific focus on drug resistance, diagnosis, transmission, and host-pathogen interactions. Dr. Shaikh is Research Officer at the Foundation for Medical Research. She has worked as part of a team on the development and optimization of mask-based patient aerosol sampling for TB detection. Dr. Renu Verma is a faculty scientist at Institute of Bioinformatics, a non-profit research organization based in Bangalore. A molecular biologist, Dr. Verma designs point-of-care diagnostics. She tests pathogen detection methods and personalizes TB treatment. A very, very warm welcome to each one of you awesome, foursome researchers.
Thank you. Thank you. Thank you.
And Kalpana, you and your colleagues, and right now we have this awesome trio in front of us, and please, any one of you is welcome to answer and steer the conversation. I'm just taking the name of Kalpana. But
sure, go ahead. Yes. Yeah, go ahead.
Kalpana, you and your colleagues have developed an innovative and non-invasive mask-based capture of respiratory aerosols of TB patients and RT-PCR assays that can really revolutionize pediatric TB diagnosis. We are very curious to know about this SMaRT-PCR that is called, which is currently being evaluated to test TB in children. But before coming to that, can you please help us understand the current diagnostic challenges in finding TB in children and the urgent need for child-friendly TB diagnostics, which makes your essay all the more important?
Thank you. Thank you for having us over in this NTB Dialogues conversation. We are very pleased to share our work. The first thing I think I'll start with, before I delve into how we got into this mask-based technology, and talk about the issues in pediatric TB. Even recently, the reports are the report says that 1.3 million children are estimated to be affected by TB. And India has a very high burden of about 27-28%. It's about 0.34 million every year. Children are affected by TB. And the major issue with, they contribute about 12% of the burden. But the major issue is that the diagnosis of TB. There are several challenges to diagnose TB in children. First is that have a very, the symptoms and signs of TB is very similar to many other childhood diseases. So it's very difficult to differentiate TB specific symptoms in children. And when they come for X-rays and go through X-rays, usually the X-ray findings are very non-specific, unlike adults. In adults, it's more specific cavitary type of disease, which can be easily identified. But in children, the X-ray findings are very non-specific. And on top of it, they usually carry a low burden of bacteria compared to adults. And because of which diagnosis become very difficult. So the most other big challenge is that, like adults, they do not produce sputum, which is the easiest and best sample for diagnosis of TB. So they have to go through, invasive procedures like gastric lavage, which involves, introducing a tube into the child and taking out the sample, which is very traumatic for the child as well as the family who's watching it. And this is one big reason why most, parents hesitate to come for diagnosis. But in children, if you don't diagnose TB and treat TB, the mortality can be as high as 96%. So because of all this issue, if you see that even in India currently, 70% of the children are just clinically diagnosed. They don't get the confirmatory diagnosis that's required for, guiding the correct treatment. And only about 30% get the microbiological diagnosis they should receive. So these are the major challenges in TB, and that's why there is a huge push for developing non-sputum based diagnostics for children. And that's where we come in. And we started developing this mask initially with our idea that we were very keen to understand transmission of TB disease and the transmissibility of the TB bacteria. So we thought what best source is to collect the patient aerosols, which is the mode of transmission for TB. So we use this simple mask-based way to collect the aerosols to understand the impact of treatment on the infectiousness of bacteria. But what we realized in that study is that when we were doing this in adults, we realized that some of the adults who could not produce sputum, where we were able to detect TB bacteria in these patients as well. So which prompted us to check, children where the sputum is the issue. We thought this would be an ideal technology to test in children for diagnosis because the procedure is non-invasive. We just ask the patient to wear the mask for 10 minutes and ask them to do some reading or talking or even singing, and then alternate it with some cough and breathing. This is the process. It's just 10 minutes collection protocol. So we thought it will be very ideal for children. And so that's why we did a pilot study in children in Mumbai itself with collaborating with 3 hospitals, BJ Wadia, JJ, and private TB clinics, Dr. Oswal as well. And we realized that when we tested this technology in children, it was the diagnosis rate sensitivity was comparable to the standard diagnosis, which is done in gastric lavage and sputum. So that's how we got into this, and that's how we developed this technology. Yeah.
Okay, so once you collect that, once they breathe into that mask, like for people, uninitiated people and unversed people like me, we would like to understand a little more about the procedure. What happens then? You collect the mask, you take out the mask, and then what happens?
So the procedure is very simple. It starts with collecting aerosols, whatever you exhale or expel, into the mask. So the mask is a slightly modified mask that you get. We've all heard about the N95 that we've seen. So it's a kind of, when we started it was a modified version of an N95 mask. So mask has a membrane inside it. It's the membrane that collects all your expelled respiratory aerosols. And in the 10-minute procedure, when the aerosols are collected onto the membrane, the mask is removed and the membrane is then transferred into a stabilizing solution. And on transferring this membrane into a stabilizing solution, this is then sent out comes up to FMR for processing, and then we do an RNA extraction. As the SMaRT-PCR is an RNA-based technology. So we do processing for RNA extraction, and then we detect TB using TB-specific genes onto an RT-PCR, which is similar again to what was used in COVID. So COVID-19 detection is based on RT-PCR. We're doing a similar TB-RNA detection using RT-PCR.
Okay, so and then that mask cannot be used again. Obviously, you have to use another mask.
It's one-time use.
It's a one-time use.
One-time use. Okay. Can this be used in adults and adolescents also?
Yes. Please go ahead.
Yes, I think you can. In fact, as Kalpana said, we started off this whole thing in adults, capturing aerosol in adults. So it can be used definitely in adults who, for some reason or the other, are not able to expectorate the sputum.
Yeah.
So,
Yes.
and of course, it can be used in adolescents also. And the younger adolescents will be a part of the trial, the ICMR trial that has been.
Even our pilot, we tested this technology till about 15 years old age.
Okay. Because why I'm asking so is that very often, even in adults, the sputum quality is not good, and that affects the diagnosis.
That's right. That's right.
Yeah.
Our initial studies show that it works well in adults, but we thought that since the need is higher in children, first we'll initiate our studies in children for the diagnosis aspect. That's why we focused on children.
Yes.
But yes, it can be applied to adults as well.
That's right.
Right. What about the cost of the mask? I'm just asking this because if we are going to use it in endemic areas, hard to reach populations where it is difficult for the people or children to go to a tertiary care hospital or centers, and also the cost factor is there. Do you foresee right now what would be the cost of one such test? And do you foresee in future of making it more accessible to more children?
Yes, right now the cost is in a research mode. We recognize that it's a little expensive. It comes down to about all-inclusive, including the mask and the RT-PCR, it would come down to about 4,000 or so. But we are working towards reducing the cost. We've already, from the pilot, we simplified all the protocols, from RNA extraction to the way we collect mass sample to the RT-PCR. We have simplified the process. So the cost has come down considerably. We started with 7,000, 8,000 rupees. Now we've got it down to 4,000. But I think with time, with the current project going in the way, we would be able to recognize where the issues and where we can. And any technology, it needs to scale up for the cost to come down. At the initial research phase, it cannot be very cheap. We are also in the process of looking at alternative, wherever we can bring down cost by looking at alternative sources. Like as she said, there is a membrane involved. That is the most expensive part in the mask. And if we are looking at that, we use a gelatin membrane. And if we can replace gelatin membrane with something cheaper, we have tried few which was not successful, but we are always on the lookout for alternative membranes which can make it cheaper, because there are other hydrophilic membranes that is very cheap, but we will have to do some more experimentation. And if it works out, that would be great, that it will bring down the cost very well.
So one of the things I'd like to say for this ICMR project, if we could have included a costing element, not only in terms of the technology per se, but there will be lots of ancillary costs involved also in terms of sample transport and so on, and what staffing will be required in the periphery to be able to collect it. So that would have been really a valuable addition, which we hope we can incorporate into this whole process at some point in time.
Yeah. So right now your ICMR funded study is on the way. That has begun, I believe.
Yes, that has begun.
Yes. Now, hoping, and I'm sure once the study findings are favorable, then what is the future roadmap towards validation, approvals required so that it can be introduced in India and other TB programs globally? Is there a roadmap for that? And what challenges do you foresee in that? I'm very hopeful that it will get favorable results. And I'm sure so are you.
Thank you.
Yeah, so the ICMR study that we'll be starting, we've already started, is actually divided into three main objectives, which are like phases. And the idea of the ICMR study is to understand the diagnostic performance of the SMaRT-PCR as a whole. So that is, integrating two parts of it. One is to understand sensitivity, specificity on a very technical term, and the other is to understand the acceptability of the mask also. How acceptable is the technology, with the users? That is, at the site, we have doctors who are going to use it, the sample collectors and others. And we are planning the ICMR study in 3 different phases in different ways. So the first phase, the first objective of the study is about testing the SMaRT-PCR in an urban setting, which is, resourceful settings in this way. Again, we are collaborating with the 3 hospitals that we had collaborated with our pilot study, as well as the hospital in Delhi. We have the Lady Haraj Medical College in Delhi also collaborating for the first phase. In the second phase, the study is more about shifting to a low resource setting, which is a sub-district level hospital, a sub-district level facility, and the surrounding rural hospitals. So every time the study is going to be connected in something that we call as the hub and spoke model. So if you look at the first phase, we at FMR become the hub, and our surrounding tertiary hospitals and clinics become spokes from where we get the samples. In the second phase, we would create a different hub and spoke in a sub-district facility or a rural facility, which has lower resources. And in the third phase is where we'll be validating across India, creating different hub and spoke models. And by the end of this study with favorable results, once we understand how the technology has been validated, the next steps is to see how it works with the program and how we can take it forward. We do accept certain challenges coming up. We would also like to see how the technology works internationally, and we are talking to consortiums on testing it in India and abroad also.
One of the things which we are anticipating is that currently the different thing about our technology is that we are detecting RNA, which is not the standard practice in TB. So one of the challenge we are anticipating is an acceptability of changing it from a DNA-based technology to RNA is one challenge. From the system point of view, we see the challenge, and we are trying to bring in the fact that we should integrate different health systems. So we have a lot of resources that's created as a part of COVID-19. Because ours is an RT-PCR technology, if TB is able to integrate with the COVID-19 health vertical, then I think there will be a shared resources, and that's where better utilization of resources come in. That's again as a challenge from a programmatic point of view, because they work in silos, and integrating that may be another challenge we anticipate. But I think we will have to keep having a continuous dialogue with all the stakeholders to see where we can get this technology adopted. But I think once we prove it that the results are good, then I think that will be easier to convince the next phase.
Yeah, but I think you should talk a little about your sensitivity with the gene expert.
Yes.
Yeah, so one thing, actually, the first thing that struck us when we were trying this technology is that if we use an existing technology, it would be easier for us to integrate. So we first combined a mass sample with gene expert, and we did a head-to-head comparison of mass gene expert versus mass RT-PCR. But when we did gene expert, we were surprised to see that we had only 13% sensitivity as against 75% sensitivity in RT-PCR. So this is a huge difference. So I think when you are looking at reaching the NTB goals, sometimes the current technologies have their limitations. If we want to really do something worthwhile, I think we'll have to move beyond current technologies and have the newer technologies integrate. So we hope that through this project, we'll be able to bring that change in TB.
And even I think, correct me if I'm wrong, but even when you use conventional gene expert technology using conventional samples, and they were negative in gene expert, the mask turned out positive.
Thanks. I think that's a very important point which I should have mentioned as well, that we had at least 6 patients who were gene expert negative in the standard reference sample, but they were mask positive. Even in adults, we had seen that where gene expert had failed, we had picked up by mask. And interestingly, we had one child who was who was referred to us as a non-TB patient because the child did not have any TB symptoms. The X-ray was clear, and doctor referred the child as a control patient. And when we did the mask, we got thrice we tested, the mask came positive. And then we communicated that to doctor. He went and did more advanced HRCT and other things, and found out that the child actually had a lymph node TB, which was not detected and did not have symptoms. So there is, I think our technology has a lot of potential. Even in the absence of symptoms, we may be able to pick up TB, and that's what we're hoping our study will show how much we would be able to do that.
Thank you. And we have many interesting questions coming up. And I would just request the audience and listeners, if they would like to ask the question themselves, rather than I read them out from the chat box. Just raise your virtual hand, please, and be part of this very, very vibrant and important discussion. So Dr. Renu Verma has a question. Dr. Verma, would you like to ask yourself?
Thank you, Shobha.
Yes.
Thank you so much. Yes, and congratulations to the team. This is just fantastic work. I was wondering, in terms of gene expert sensitivity, how many RT-PCR targets do you have on your panel? Because that might also affect the sensitivity part.
So I think when we've done our pilot study, we were looking at specific targets on the RT-PCR panel. It's a 16S and rifampicin RPOB gene target. And over the time, we've now improved and made the technology more simpler as we've upgraded it. Currently, we'll be looking at 3 TB specific targets, another additional target, and an RNA screen for control. As well as now we have made our RT-PCR to even look at resistance genes. So the test can finally even tell you resistance towards rifampicin and isoniazid.
Wow. So when you said 6 which were not diagnosed on Gene Expert, you detected those. You had all these markers on that?
Yes.
So that was the pilot study.
So the pilot study.
16S and
RT-PCR.
Oh, that's incredible. That's incredible. Congratulations.
Thank you.
And there was a question from DT of Villupuram district. Of course, I think you have mentioned it, but could you please again tell the specificity and sensitivity of the test? And again, he has questioned about the high cost which you all are trying to reduce. So a little bit on that again, perhaps.
So our pilot, in our pilot study, where we had about 24 treatment-naive patients and equal amount of children who didn't have TB, we had a sensitivity of 75% when we considered that when we put up a criteria that both genes needs to be present to say positive, which is the 16S and our RPOB. If we say single gene, any gene is fine, then we got very high, 96% sensitivity, but the specificity was low. But when we had a stricter criteria that both genes need to be present to say positive, we had 75% sensitivity and specificity was 95%. In the same cohort, the gene expert had a sensitivity of 71% in the the sputum gastric lavage samples. So that's our sensitivity specificity. And cost, I think right now, as I mentioned earlier, we are working at a cost of ₹4,000 for end to end. But we are working towards reducing that cost by looking at alternatives. And I believe like COVID RT-PCR, which started off with 4,000, but when it came to the mass use, it came down to 600 rupees per test in at least Maharashtra. So I'm really hopeful that even with scaling up of this technology, we should be able to bring down that kind of
Yes, we have an example of lowering costs in, say, whole genome sequencing technologies. When I first started doing genome sequencing, the cost was rupees 80,000 per sample. I'm giving an average cost. And now the cost is now 4,000 to 5,000 rupees.
Yeah.
So with more use and with more interdisciplinary engineering, bioengineering research, you can get the costs down. And with more use, of course, the costs will come down. I'm pretty confident of that. But our first job is to see that the test indeed works and is adaptable to conditions that would make the test more equitable to our population.
When will this study be over? Just want to know, because there are questions about that. If found safe and effective, how long will it be till it becomes available for people? So the first question is, when do you expect the study to be over? And then the other processes begin.
Results by phase 2.
The study is 4 years long. Our phase 2 is results to be expected around the 4th year of the project. But we would have a very good idea in the first phase itself, whether it is, how comparable it is to how the results we got in pilot. So that we'll get an indication how well it is adaptable. And then later it is generating the whole data plus, of course, the operational adaptability to even rural settings. So I think all kind of, by end of 4th year, we should be able to give something that is translatable to the public. Yeah.
Yes.
But I think before it gets translated into the system, the test would have to undergo, say, for instance, in India, at least they'll pass through the health technology assessment cell of the Indian Council for Medical Research. So there are a few mandatory steps that the technology will have to go through before it gets. But I hope it can be done ASAP.
Yes.
We take far too long in assessing and then rather putting it to use. And if we find it good, then it will save the trauma for a lot of our children.
And we should probably moving, once the phase 1 is over,
Well,
we should
start moving towards the
HTA.
HTA. Start sort of sequentially, but simultaneously.
Yeah.
So,
Amen to what, Nerges, you have said just now. That
Yeah,
yes,
absolutely.
yes, absolutely. Ambreen, would you like to add something or share your thoughts on it? You have been part of the team.
Yes. So that's what we were saying. I mean, as the technology move forward, right? We anticipate with every phase we would be doing interim analysis, we would be presenting those, and we would have a better idea as phases move, how are our goals being achieved, how it works with our urban settings, how easy is it for us to transfer the technology out, and how well it works in the low resource setting, how it works with other people than us, when that's the validation part of the technology, which is also very important, right? It works currently in our hands and we want to see it with the validation, how it works with other hubs and spokes. So we'll not just be transferring the use of mask, which is a non-invasive technology, we'll also be teaching and training others to use this technology. And that would give us more reliable results towards the end of 4th year on how well the technology works, of course, in terms of its diagnostic accuracy. And this is a large cohort. We'll be doing this in about 1,200 children spread over a period of 4 years. And then we'll also have a very good idea on how easy it is for us to transfer out the technology also.
Just one more question about the mask. It just covers the mouth of the child, or the nose is also covered, or just the mouth?
Yes, the nose and the mouth.
Yes. Anything else any three of you would like to add to what we have been asking or trying to converse with? Any point which we might have missed? So,
yes.
I think no technical point as such, Shobha, but what I would just like to say is that as a director, and the team has been, these two mask ladies have been working pretty hard in getting it from the conceptualization phase to a operative phase, and we're very grateful to SMaRT for giving us this opportunity to be testing it out. And there can be no greater pleasure for me that the Institute has managed to contribute something useful towards a phase of in a TB patient's life, which is extremely important, the childhood phase, because if the child gets saved from very virulent forms of TB and is diagnosed early and given appropriate treatment, it will help to better their whole life, in fact, without the aftermath of complications and so on. So to me, it gives great satisfaction to be able to take part in this. Thank you.
There is a question from District TB Officer of Viluppuram, again, that even in CBNAT, in RG sample, expectorated sample in pediatrics TB, the positivity is low.
Yes.
How far this will work with such a high cost?
We don't expect the cost to remain.
We don't expect the cost to remain this. It's in the research mode right now, and we were, as I said, several factors that matters for the cost. We will be assessing in not quantitatively, but qualitatively. We will be assessing that as well, and we hope that. I do understand the GeneXpert, I think, has a very only 45 to 50% sensitivity in childhood samples. But again, our pilot has shown that we can do better than that. So hope we will improve that, and children with coming in with signs and symptoms of TB. Then if the shift is big, I think the cost sometimes, instead of undergoing, if the technology is not picking up the test, then the doctor ends up doing several other tests to prove the TB, right? And hopefully on an integrated level, one test, if it can answer, then the other test cost can be saved. So in terms of, we cannot just see the cost as the test per se. We'll have to see the other elements when it comes to costing costs. Yeah. It's not just this test. So on a larger scale, this might work out more economical than doing several tests to prove the same point. Yes,
And
it
have
will
you?
reduce.
Yes, sorry. Yes, please.
Somebody is asking a question that
Yes,
can
yes.
reduce diagnostic delays. Absolutely.
Yes.
And if I may just add at this point, this test also has potential for other things. It's not just for pediatric and adult TB diagnosis. It can also be used for surveys based on the fact that even people who do not have distinct TB symptoms are still transmitting TB. This has been one of the most striking results obtained in the last couple of years from a number of groups globally. So if you can use the mass technique to be able to pick up non-symptomatic patients within populations, that itself would be another very useful dimension that the test could fulfill.
Have you tried the TrueNat machine for the sample testing? I'm talking of that because it has certain advantages over over the Gene Expert.
No, not till now, but hopefully in the future. We've spoken to them a few times. Let's see if in the future, if it gives an opportunity, we will do it.
Okay. So thank you very much. We are continuing the conversation now with Dr. Renu Verma. Dr. Verma, amongst your numerous scientific contributions, which do you consider best in the context of their deployment for accelerating progress again to end TB, especially in high TB burden countries like India? Over to you.
Thank you, Shobha. Thank you. Thank you, Shobha. Am I audible enough?
Yes, very audible.
I think one is, of course, the diagnosis part and early diagnosis of drug-resistant TB. So we were recently funded by ICMR to develop a custom nanopore sequencing panel, which would, without culturing, so we will have a culture-free detection of drug resistance when the patient walks in. And we are hoping that the turnaround time would be 48 hours. So that is going to save a lot of time and cost in terms of, treating the patients and personalize the dosing which we need. And I don't know, actually, I was informed yesterday and I have small slide, a presentation on the mask we prepared. Do we have around 10 minutes? Or
yes, please go ahead. Please go ahead.
Yeah, because I think audience had this question, how that mask looks. And we may have a similar thing which we tested on the COVID-19. I'll just quickly share that.
Yes.
And maybe we can talk about other things later.
Yes.
So are my slides visible? I think I'm just sharing my screen now.
Yes.
Okay. So I'll just talk about this mask tool, a similar thing we developed in 2020 during COVID-19 to capture and sequence the airborne pathogens for the detection of drug resistance as well as transmission surveillance. I'll start with this interesting story. So in 2020, the CDC guidelines said that if a person is in close contact, a COVID-19 positive person is in close contact for 15 minutes, a person is at risk. And based on those guidelines, couple of schools in the United States, teachers started telling students to up and walk around every 12 to 14 minutes to avoid infection risk or exposure risk. And the Iowa Department of Public Health also released these guidelines telling that if you're exposed for 15 minutes, you are at risk and you need to quarantine for exposure. And then later in October 2022, there was a report released, October, that a team, several members of National Football League team were infected with COVID-19. And when they checked the CCTV footage, they found that none of the members were actually exposed for 15 minutes. And then CDC comes up with a revised guideline saying that if you are exposed for cumulative 15 minutes within 24 hours, then you are at risk. And then we started to wonder, there is no empirical evidence, like what is the exposure risk? Because these guidelines people are following blindly. And actually, if you are moving students from one room to another so frequently, the chances of transmission are even higher. So we started this study to see, can we actually quantify how much a person is releasing in the exhale breath, and can we correlate with the nasal swab, because there is a possibility, because so many patients were asymptomatic. So can we actually just quantify that and have an empirical evidence on that? And because 15-minute rule was used widely to decide the public guidelines, and that time there was no such tool which was sensitive to for such kind of sampling, and we hypothesized that, and it is actually very intuitive, and we might know that the exposure time alone is not enough. The individual was exposed under what circumstances is also important. Like the ICMR teams mentioned that you are not there saying they're asking kids to talk or sing or just yeah, cough or whatever when they're collecting the mask, because that's a very important thing to consider. So there were two preliminary studies which used this face mask, but their sensitivity was quite marginal, 38 to 40% in detecting. Shobha, that's how the mask looks. I mean, their mask prototype looked, where they had gelatin filter strips, and you just wear mask for a certain time, and then you extract RNA from the gelatin filter. So our first question is like, 38 to 40% is a really bad sensitivity. Can we improvise this, and can we design or change and have our own prototype to kind of work on that? So, and the other question was, how do we transport the mask to the lab? How do we avoid contamination of the mask, even when because these are small factors which really matter when you are collecting samples in the field. So I designed this prototype where I took the cutout of 4 cutout of this gelatin membrane filter, and there are small petri dish, same petri dish, which you can fit in the mask, inside the mask near the pout, and ask the patient to wear it. And then after the patient is done, even if they're collecting in the field or in the house, after collection, you just put the lid back on. So that way what happens is that you avoid contamination. And now the second thing was that we wanted to test the integrity and stability of RNA or DNA on these mass samples. So we also did some R&D to find out what would be the best media which stabilizes the RNA but also disinfects it. Because same with COVID and tuberculosis, we do not have access to BSL facility everywhere. So we want to make sure when we collect the sample, we make it, we process it in such a way that it can be done on the bench. So we used an FDA approved media which instantly stabilizes the RNA, viral RNA, and also kills the virus. And this was the prototype. And then when we optimized our assay, we wanted to see that how much from the same patient, how much virus we are able to quantify or detect when we are getting exhale breath and a paired nasal swab from the same patient. And we also did RNA-sp gene, because sometimes when a sample is negative for the virus or any other pathogen, it does not necessarily mean that the patient is negative. There is a possibility that the sample processing was wrong, something happened during the processing, or it was not collected well. So we take RNA-sp, which is a human gene target found in oral swabs or cells which are released in exhaled breath, as a positive control. And we said that only when we detect RNA-sp, we take those samples for further processing. And so this is how masks look. And then the next thing was we wanted to quantify. So we recruited patients from 3 different clinical trials from Stanford University. And so one group wore mask for 30 minutes because we wanted to know, is time alone enough or not? And then the group B had two categories where they were given 2 masks, and the group B wore mask for 15 minutes, where we gave them a script to read, or they can just talk to the interviewer, and 15 minutes they were instructed not to talk. And this is just the patient characteristics. I will just nod. So we found that our sensitivity was close to 75% in our mask. And as expected, when a person was talking versus not talking, there was a significant difference in terms of mask positivity and the viral load. You can see that we could detect up to 10 to the power 6 copies while talking to 4. So there was 100-fold difference in terms of viral copy when same person is when he's talking versus not talking in terms of shedding. So that becomes important when we want to design any collection protocols. We could give them a script so that we know that a person was reading this and talking, but we also instructed the patients that if they feel uneasy during the sampling, they could tell us, and we would get rid of the mask. But then none of the patients reported any kind of an uneasiness. And this is just a viral RNA thing. I will not. And then we also found, of course, age had a relation with how they are shedding the exhaled breath. And then, and then for the first time, we demonstrated that we could not only detect and quantify the virus from exhaled breath, we could perform whole genome sequencing from those. So we first time demonstrated that if you take whole genome, you take virus extracted from exhaled breath, you could sequence them with a very good coverage. Most of our samples, sequencing targets had up to 100x coverage, which is enough to build transmission networks and understand and study how the virus is transmitting in the community. Our idea here was that as the COVID was, COVID started, and then after when people were vaccinated, we wanted to do a mask pooling study in the congregated settings or a hospital settings where we could pool mask. So we don't have to perform assays for individual mask, but we know that these many individuals were there in certain room or public transit. We give them mask, we pool it and run single assay and see if we find anyone positive there. So that drastically reduces the cost of screening. So we wanted to use that. We proposed this mask as a screening tool. And these are some of the conclusions of the study where we found that our mask prototype was much more sensitive than the previously reported mask prototype. And these are just the partner, and this study was supported by Bill Gates Foundation. And thankful to my team and collaborators. And I'm open to questions now. Thank you.
Thank you. And now the hope is that all this awesome research translates into public health gains as soon as possible. Of course, can't be very soon, but yes, giving it scientifically proven and scientifically approved, because unless it reaches to the people for whom it is meant, I think the work is half done or even less than half done. This is the most important part of work. But there are, so as all of you know, there is so much of blockage and challenges that lie ahead. And it takes a long time before the work, the backbreaking work of scientists really translates into public health gains for what it was meant, for what the scientists and researchers were working for. So with this, we come to the close of today's session. And thank you, Nerges, Kalpana, Renu, and Ambreen for this very exciting and informative and inspiring discussion. And it's not the end of the discussion. We are just closing today, and hopefully we will meet again. And long live you women scientists and researchers. And may your tribe increase, and amen to that. Namaste.
Thank you so much. Thank you for hosting us.
Thank you, and thank you to all the
Thank you. Good luck to the team. Thank you so much.
Thank you. It's a rare occasion where we have a panel of female scientists, given the conditions under which they have to work. So thank you for that.
Thank you. very
Namaste and goodbye.
Thank you. Good
Namaste.
luck to the team. Thank you. Thank you for hosting.